Welcome to Physician Focus. I'm Dr. Bruce Carlin. The number of joint replacements is soaring in the United States as more than 1 million people a year are getting total replacements, usually for their hip or knee. As baby boomers age with arthritis and other conditions, but still wish to remain active, these operations are expected to continue to increase. This edition of our program will discuss the medical procedures of joint replacements. We'll examine such areas as what patients should know before they choose such surgeries, how long these replacements are expected to last, and complications that could arise, among other questions. With me for our discussion is Dr. Scott Oliver. Dr. Oliver is a board-certified orthopedic surgeon with Plymouth Bay Orthopedic Associates in Duxbury, Massachusetts, and specializes in knee and hip replacements. He is also chief of orthopedic surgery at Jordan Hospital in Plymouth, Massachusetts, a position he has held since 1995, and is on the orthopedic staff at New England Baptist Hospital. He is past president of the Massachusetts Orthopedic Association and a fellow of the American Academy of Orthopedic Surgeons. Welcome, Dr. Oliver.
Thanks, Bruce. Great to be here tonight.
Well, let's start by saying, why so many? What's the boom all about?
Well, there's a couple of factors right now. I think if you look back right now, the numbers simply are increasing of people. The baby boomers are really coming, and the first boomers right now are about 67 years old, and so we're getting into the time where they're getting to the point where their joints are beginning to show some wear. The other problem you have is the fact that our population, unfortunately, is overweight. And that extra weight, that extra 5, 10, 15, 20, sometimes 100 pounds, actually wears down the joints far faster than ever before.
Sort of get magnified. The more you weigh, it actually gets magnified when it gets to your hip or your knee?
Yes, exactly. So that rubber coating they have on the bones, actually the part that's in the joint, wears out, just simply like a tire tread. And that tire tread then wears out, and then we have bone against bone, then we have people with a lot of pain. That's when they start seeking us out. But why don't we talk about what should they do before?
All right. Well,
we'll
get into. First off, who's a candidate for joint replacement?
Well,
how do you make it there?
How do you make it there? Well, usually you have to get there if you have some joint pains, and it can be any place in your body. You'll have some part which becomes sore, and that ache, and it'll be happen very frequently after activity. And so, as that gets to be more on your radar screen, you have to realize that maybe you should take some ibuprofen or Aleve. Sometimes ice on an inflamed joint will help out a lot. Inflammation, that's what happens with arthritis. So it becomes inflamed, like red and hot. So what you do then is you use anti-inflammatories like ibuprofen or Aleve to bring down the inflammation. Ice also helps, and by doing so, that's the first level of treatment for most inflamed joints.
So the arthritis, the itis part, of course, is the inflammation.
Right.
And they come in a couple of varieties. We've got, of course, the wear and tear ones, which you've been alluding to, and that's the largest share of them. Is that right?
Yeah. Yeah.
The wear and tear, just you're banging on the joint for a lot of years, and
it just simply wears out.
And then there are a whole bunch of folks that a smaller group that have inflammatory arthritis.
Right. There's some diseases out there like rheumatoid arthritis or psoriatic arthritis, or some different types of gout will lead to like really significant arthritis to the point where they need help. But I'll be honest with you, most of the time that right now that we take care of in our orthopedic office, I'd say at least 98% of them are people who have just wear and tear arthritis, otherwise known as osteoarthritis or degenerative arthritis. Those are the different names for it.
So, so you alluded to a couple of things that we can do. Some anti-inflammatory drugs that are over the counter. What other things can you do to I think keep those joints preserved while...
Right. One of my lines right now is the fact that I think it's important that people, they have to know that they have to get in good shape to get old, because that way you'll have some fun. And that means exercising it regularly, keeping your joints moving. Many people will figure out very quickly that they feel better if they exercise. So even if that joint bothers you some, it's in your best interest to go outside and take a good walk. Burn up some calories. Keep your heart in shape. Your heart's another muscle, and it has to be exercised. And unless you have good hips and knees, you can't exercise your heart. And that heart has to be able to handle the stress of life. So that's why it's all important that you keep your skeleton going so you can keep your heart going. Okay. That's how I look at my role.
But I just think of Mark Twain's famous comment. He said, if I had known I was going to live so long, I'd have taken better care of myself.
Right. Yes, exactly.
So you've got medicines, you've got exercise.
Right.
A little
weight
change,
reduction.
Weight reduction.
Yeah, that's a big one right now. Okay, and so we need to get people back in shape. They need to be able to lose weight. Unfortunately, I have to talk to some of my patients quite frankly and say they may be a candidate for bariatric surgery. In other words, some sort of weight reduction surgery as opposed
weight
to
reduction,
gastric bypass, things like this before they actually discuss any types of surgery with the orthopedic surgeon.
Are you saying that there are some weights that are too much
Yeah, I think you can, even if you put a new knee joint in a person who's too heavy, that new knee joint will only last a short period of time, maybe a couple of years. And so that's not really helping the patient long term, okay? And when you do these type of surgeries, they really have to help people out, say, for 10, 15, or 20 years. That's what my goal is to be able to help people out for a long time.
You brought some toys here, so maybe you can start by saying, what does a normal joint look like, and explain some of the
well, I'll show you right here. This is a pelvis right here, and you can probably figure this out. And this is what you have right here is you have the ball and the socket. And so with the hip joint, you have just a simple joint like this works like this. And there's a rubber coating on here on the ball and also inside the socket right there. And that rubber coating can wear out. Now, it can wear out because you may have a genetic predisposition to having bad hips. You may have a hip which just ever so slightly off the socket.
Out of line?
Yeah, out of line. And that's called dysplasia. And that little bit of malalignment will cause a wear of the articular surface in there early.
The articular surface being the joint surface.
Thanks. Yeah, that's the rubber coating that I was talking about. So that hip will wear out. Unfortunately, I see patients who are 40 years old, who are not overweight, 46 years old. Even in the last week, we've operated on some people who are less than 50 years old because they have so much pain with the hip joints. The knee's a little bit different.
Before you go, what typically a patient who has hip pain, where is that felt?
Yeah,
because
thank you.
A lot of my patients come in and they say, I got pain, and they point to their side.
Right.
But when you talk to the joint itself, you're really talking a different kind of symptom. Can you explain that?
No, thanks for saying it. The things that happens with a hip joint is essentially you start getting a burning pain. It almost feels like you pulled a muscle right in your groin area. If you draw a line right up the line of your pants, that's where the hip joint is. So it's right dead center in the area of the groin area, and that's where the ball and the socket moves. That's where the discomfort starts. Many people say they have pain on the outside part of the hip, and that pain is simply a bursitis or a tendonitis that can occur over there, sometimes suggesting that there's a bad hip joint going on. But most of the time, that can be just treated with medications and injections and therapy. This is where the bad pain is, a deep pain in there.
And the other thing, my patients always say they can't get their shoes on.
Right. You start, because the hip joint starts kind of basically grinding down to a halt, just like a rusty joint or something, in that you lose the motion. So some of the first signs of a bad hip joint is pain in the groin and inability to get in and out of the car, for example.
Okay. Yeah.
Is they'll have a lot of pain like that. And that pain will persist even after the activity, many times at nighttime. And they'll start seeking help because of the ongoing pain. And they'll take some ibuprofen to leave. They'll see their primary care physician and eventually end up in an orthopedic surgeon's office, as you well know.
Absolutely.
Yes.
So we work hand in glove.
Yeah.
You want to talk about knees?
Knee joints. This is the knee joint right here, and the knee joint's a little bit more complicated. Around what we have is several parts of the working surfaces. In the hip joint, you just have the ball and the socket. And the knee joint has 3 areas of contact. One is between the kneecap and the thigh bone right here, where it kind of wears like this, where people have, when they go up and down stairs or they sit too long, they'll feel some cracking sensations, like creaking sensations around their kneecap. That's where that part will wear out. We also have some little shock absorbers inside the knee joint, and this is called a meniscus. We used to call these the cartilage of the knee joint, but now we call it the meniscus, one over here and then one over here. And these little things prevent the 2 bones from banging against each other and help out the knee joint's normal motion.
Shock absorbers.
Yeah, right. Now, when we look at a knee, what we can see is that this knee is relatively straight, but only 2% of the population has a straight knee. The rest of us have a little bit of a bow like in this, about 58%, and the other part of us have a little bit of a knock-kneedness. This is a right knee right here, so this is like a little bit of a bow leg right here. What happens if you walk around for all those years, say 50, 60 years, walking around a little bit bow-legged?
So what you're showing is a little separation on the outside of the right knee. There.
Yeah, right there, and all that extra pressure over there causes a meniscus tear.
So there's pressure on the side that's open. The other side gets warm.
Exactly. Yeah. Yes, exactly. And then all of a sudden you realize that either your father or your grandfather or someone is getting more bow-legged, because then that pressure continues like this and continues to wear out. This gives a lot of inflammation right in this area. What you have is a meniscus right here, which will tear, but then also right here you have that rubber coating to the bone right here. So with time, this wears out just like a tire. So initially you start off with a good tread, and eventually you get down to a ball tire, and eventually you get down to a rim. And then you've got just a lot of discomfort in there.
You hear of your great athletes who have been perhaps not as kind to their knees as they might, having trouble walking later in their careers.
Yep. Joe Namath has had both knees replaced. People like that. Most of the football players have had to do that because of the wear and tear on the knees. So you do have, these are all the components. The genetic component. You'll have families of bad hips and bad knees, but you also the weight. You'll have the injuries and just basically wear and tear as time goes on.
So let's see, we'll go one step further. What can you do about it?
So what we can do then is we also give chicken shots. And these chicken shots actually are made from rooster comb, and it's synthesized into an injection that we can put into the knee joint. And this is a gel that we put in there, and that is a shock absorbing gel. And it will help out patients, probably about, I'd say 50% of the patients who have moderate arthritis, not severe arthritis, but moderate arthritis will be a benefit from doing these injections. And we can do that again if we...
And they're somewhat durable.
And they work well, and they will work for 6 months a year. I've just seen a number of my patients in April right now because they want to play tennis in the summertime.
So, but now what do? You've done all the shots, you've had your steroid, you've had your chicken cartilage.
You've got your gastric bypass, you've done the whole thing, and you come in, you're skinny, and your knee still hurts. Okay. Yeah. Well, then at that point, we have to start talking about replacement. Now, what has to happen then, for example, in the knee, this part's all worn out. So this part is actually replaced with metal and plastic. The same thing happens with the hip joint. In the hip joint, for a while, we were doing something called surface replacement, but the problem is that the surface replacement had a part that was called metal on metal. And that type of bearing with metal and metal created a little friction, and that little friction created little tiny ions that would go around the tissues there, and it's been a problem. So we've now backed away from doing surface replacements on hip replacements, and so now we're just still left with doing the full hip replacement, the total hip.
So pull out some more of your toys here.
Yeah.
This is pretty good.
So this is a hip replacement, just to show you what it looks like. So in a total hip means that both sides of the socket are replaced. So this is what a total hip would look like. This is metal right here, and this is a ceramic.
So we're on the back of the hip here?
This is, yes. We're looking at the back of the, now this is looking right from the side.
Okay.
And this is the ceramic ball with this is a acrylic model, and the replacement is going right down the middle of the marrow.
So all the clear stuff is what your bone would
yes,
be,
exactly.
and the dark stuff is
yes.
the metal
actually,
that you're putting in.
Yes, so we actually use metal. Sometimes this socket right here is held in there with some screws just to give us some temporary fixation. Most hip replacements in the country right now are done with what we call press fit type of surgery, where we actually press fit this device in here, just kind of jam fitting in there, and the bone will actually grow into it. So after a while, just like when you pound a nail into a tree and about a year later you try to find that nail, it grows over, and the same thing happens with a prosthesis.
So
the bone grows into the prosthesis.
Now, you actually, the prosthesis itself isn't a solid piece. You've got some...
It's actually got a rough surface to it,
so
and you can't really see this too much. Yes, and it's actually, sometimes it's also coated with something called hydroxyapatite, which is a chemical just like your own bone. So the bone senses that and grows into it and bonds it in there. So you get a good fit, and this can last for 15, 20 years. The biggest problems we have so much now is not so much the fact that the bonding of the hip replacement, but the bearing surface. So now we're looking for the perfect bearing surface so it doesn't wear out. And we're getting closer with that too. The plastics we have and the ceramics we have, the metals we have are now another whole advancement over the last 2 or 3 decades.
So when we do all of this stuff, what do I need to do if I'm a patient? How do I prepare for this surgery, and how do I make sure that, because I don't get an awful lot of shots at this.
No.
You get maybe at most one redo.
Right.
So how do I protect it?
Okay. I think the best thing to do is understand the fact that this is a pretend hip. It's a good hip, but it's not God's hip anymore. And you do have to do some activity modifications. You can't play basketball, and you can't run or jog because you'll break that bond that we have between the bone and the prosthesis. And that's the biggest problem, is that I do have to, and you'll have
those will slip and give you pain.
And then, yes, exactly, thanks. And the prosthesis itself will become loosened in there, and if it becomes loosened, there's will be some thigh pain, and that pain will continue with every step, and that gets to be a major problem. That would require revision. Revisions, fortunately, don't happen that often, but just with everything else going on, with the number of hip replacements we're doing is going up, the number of revisions are going to be going up as well. So that's a difficult thing. Usually, from a point of view of the patient, it's best to be in great shape, make sure your weight's down, and if you have any history of heart disease, make sure you see a cardiologist before the surgery, just because that's the biggest stress on the heart is the entire surgical event and everything, and anesthesia.
And what about preparing it in terms of my physical activity? Do I have to, because it's going to take a while. These things, you don't put them in and then the next day go walking.
No, and so many times what we'll do, a good surgeon would send a patient to physical therapy before. We call this prehab or prehabilitation, to make sure that your muscles are as strong as they can possibly get, to make sure that you're all set to have the surgery, and make sure your body is as strong as you possibly can get as well. So those are all great ideas to make sure that you're all set for your surgery. I'm going to go over to the knee for a moment.
Okay. Good fun stuff.
Yeah, no, and so what we talk about when we do this knee right here, what has to be done is that this part has to be replaced, and so this is now a new type of technique that we're doing, this is called a partial knee replacement, because only part of the knee is replaced. In this case right here, you'll see the bone right here has been replaced by this metal piece right here.
So the metal doesn't go all the way across, no, it's just replacing one of the surfaces.
It's a surface, yeah. And so we call it partial because it's just the part of it. And right down here on the top of the shin bone, the tibia, you also have a piece of metal. Now with the knee replacement, 95% of the knee replacements actually are bonded with a cement in there. This is basically the standard of care. So we basically put this in here. We have a robot right now, which has been, I think 3 years old in the country, and this basically will burr away this bone perfectly, mill it down, and then we are allowed to put this prosthesis in there with metal up here, metal here, and then we put in slip in a plastic insert. and this will provide, remember we talked about the fact that many people have a little bit of a knee which is a little bit canted like this.
Yeah.
So we put this device in here and we can straighten it back out. So you have a knee which is a little bit bowed, and we can bring them back to where they were when they're 20 years old.
Now, just a question on that. That must require a bunch of physical therapy to get used to walking
Does take
normally.
a while, right? And many times I'll tell patients that it'll take about a full year for your muscles to fully recover and for you to feel like you're walking normally again.
But you're changing from the knock-kneed or the bow-legged that got you there in the first place to straight.
Right.
That's yet another layer of, learning.
There's a whole thing going on right now in orthopedic surgeons about whether or not we should make people all perfectly straight or if we should leave them what we call undercorrected and leave them a little bit bow-legged still, because that's the way they were when they're, like I said, when they're 20. And so this will be like now a total knee replacement as opposed to the partial. The partial is just this part, but with the total knee replacement,
that one's missing the kneecap.
Yes, thanks. This is missing the kneecap right here. The kneecap would be right here, but now with the total knee replacement, both sides of the knee are replaced, both the inside part of the knee and the outside over here. Again, this is a metal, and you'll see this. We think this is a total knee but this is really a surface replacement. We basically cut down the bone, mill it down, and again, and I've been using a computer navigation to do this, but many doctors right now, actually 90% of knee replacements are done using large instruments still, just to line up the knee and go from there. But this is the type of thing that you'll have, and we have a knee which works very well like this, and allows a person to go pain-free again.
One of the things, and I didn't ask you this before, but how do you get all the tendons lined up when you've put all this metal in there?
Well, what a person will see is they'll see the incision on top of their knee right from probably about any place from 4 to 6 inches long, right along this area here. What we'll do is we'll actually slide the kneecap over like this, and we'll take some retractors or some little metal tools.
So you're pulling all the tendons out of the way.
So you can go right down to the end of the knee like this.
So all the orange parts are tendons.
Right. Yeah, ligaments and tendons. Yeah. You can do your work and then slide it back over, and it's amazing how the body can heal.
Well, we've got a ton of stuff and we don't have a lot of time. Just a couple of things. How long do they last?
Knee replacements. If you're good to your knee replacement and you're of good weight and you do your activity modifications, so you kind of learn to live within the rules. I mean, a knee replacement should last for 20 years. A hip replacement should last for 20 years. We've now gotten to the point, when I started this business, we actually had metals break, we had plastics wearing out. We don't have those problems anymore. Like I was talking about, the fact is that when we put the prosthesis in there and we cement it in, if you don't take care of that cement, just like anything else, if you drop a hammer on those old bathroom tiles with the grout and everything, that little fracture, that little crack in there will continue to perpetuate all the way across the entire...
propagate right through your bathroom floor.
Right, exactly. Okay, the same thing happens with knee replacements. So it's important that a person understand that they need to take care of things.
And that's that prehab followed by rehab followed by constant vigilance, because it's, as you say, it's not God's original equipment.
No.
What other things do people have to worry about? I know some of my patients worry about, can I get an MRI afterwards?
Yeah. MRIs are using magnetic waves. So for that particular knee, you will not be able to get an MRI. But you will be able to get an MRI, say, for example, of the hip above or the ankle below. That will be fine.
Or some other part of the body.
Or some other part of the body, because it's very specific to that sort of thing.
In the old days, we used to... that one, it's a knee replacement that didn't work.
Right.
In the old days, we used to worry about possible infections. Have we learned something now?
Yeah,
do you need prophylaxis every time you antibiotic prophylaxis
Right.
when you have other procedures done?
Right. There's initially one of the problems that we have with any sort of surgery at all is infection. Right now, most of the programs that we have out there do test people for a bad bacteria called MRSA. And if we do that and we understand that they actually are a carrier of MRSA and they have that on their skin, then we actually give them a different type of antibiotic to make sure that they will diminish the chance of getting infection. So you can actually get, our goal now as orthopedic surgeons is 0 infections.
So you do pretty well with that. Listen,
Right.
we could obviously talk for another hour. You've
Right.
been terrific, Scott.
Right. Thanks.
You've
Thanks,
been a
Bruce.
great guest. And that does it. We are out of time.
Great.
For more information about joint replacements, visit the websites listed at the end of our show. And to view past physician-focused programs covering a variety of healthcare topics, visit our website at physicianfocus.org. I'm Dr. Bruce Carlin. Thank you for watching.
I'm Dr. Scott Oliver. More than 1 million Americans a year are getting joint replacements, and as our population ages, this number will increase. While these operations are becoming more common, replacing a hip or a knee is a complex procedure and requires extensive preparation by the patient. So if you're considering this kind of surgery, learn what to expect before, during, and after surgery. Ask what you'll need to prepare for the surgery, including your physical preparation, communicating with your medical team, and planning for your recovery at home. Ask about what kind of anesthesia and implant will be used, how long you'll be in the hospital, what is required for rehabilitation and pain management, and complications that could arise. Joint replacements can relieve pain and allow for a more active life, and preparing properly for the procedure is a key to a successful outcome. For more information, visit the American Academy of Orthopedic Surgery.
I'm Dr. Michael Berry. For many medical problems, there's more than one appropriate option for testing or treatment. Determining which option to choose may be one of the most important decisions a patient will ever make. Yet too often, patients make decisions without a thorough understanding of their options. Shared decision-making can help. It allows patients and their providers to decide together based on the best scientific evidence and the patient's values and preferences. The Informed Medical Decisions Foundation has worked with a company called Health Dialogue to develop more than 30 programs on various aspects of medical care. These programs help patients work with their providers to make care decisions mindful of what patients most care about. Among our programs are those for cardiovascular disease, chronic conditions, breast cancer, mental health, end-of-life care, and screening and testing. I encourage you to learn more about how to get health care that's right for you by visiting our website.